I will present recent advances in the management of ulcerative colitis. Instead of making a theoretical presentation, I would like to make it a case-based approach, meaning thereby I will present real-life patients and will learn through those examples. The first patient that I am presenting is a 25-year-old female who had bleeding per rectum for 9 months, small volume diarrhea with mucus in the stool for 8 months, and she inappropriately underwent surgery for piles 3 months ago, but symptoms continue. This is not uncommon. Many patients like this are treated as piles in India in primary care setting without proper investigation. I think if when patients like this come and they undergo a sigmoidoscopy or colonoscopy, the diagnosis of ulcerative colitis will be made. What are the possibilities at this stage? Could it be infective colitis? Unlikely, because of long duration. If it was short duration, this possibility remains. Ulcerative colitis new onset is quite likely, and piles is not an important diagnosis. She underwent investigation in the primary setup or secondary setup. Stool microscopy showed no oocyst and parasite. Culture was negative for enteropathogen, and sigmoidoscopy and biopsy suggested ulcerative colitis, and there was no piles. She was managed on this line, started on 5-ASA, 400 mg 2 tablet thrice daily, no response. Therefore, oral prednisolone 40 mg per day was started, which led to response. At this stage, I want to highlight that on histology for ulcerative colitis, one can get cryptitis, crypt abscess, crypt distortion, crypt branching, crypt loss, muscularis mucosa thickening. However, cryptitis and crypt abscess are non-specific finding. They can occur in infective colitis as well, whereas crypt distortion, branching and crypt loss and muscularis mucosa thickening are suggestive of chronic changes, and they are more likely to be associated with ulcerative colitis. Ulcerative colitis may be proctitis in 30% of the patient, 40% left-sided colitis where the disease extends up to the splenic flexure, and when the disease extends up to hepatic flexure or beyond, this is called total colitis, this is 30%. Mild disease is often associated with the proctitis, and severe disease is often associated with the pancolitis. At this stage, she visited SGPGI after 2 months. We did a full colonoscopy and we found that disease extended up to hepatic flexure with loss of vascular pattern, friability and a few ulcers. She was clinically in remission with one formed stool per day and no blood. 5-ASA was continued. Steroid tapered according to the tapering rule. What is the tapering rule? You taper 5 mg per week till the dose comes down to 20 mg, and then 2.5 mg per week till the dose comes down to 0 mg. She had relapsed while tapering steroid, and what next? Now, this is called steroid dependent disease. So what is steroid dependent disease? Steroid dependence means while tapering steroid using a tapering rule, or within 1 or 2 months of stopping steroid, if somebody relapses, this is steroid dependent disease. On the other hand, after 1 month of use of steroid in adequate dose, that is oral steroid in adequate dose, if there is no response, this is called steroid refractory. There, azathioprine is a good drug. You use 2 mg per kg per day. Typically, we put a ceiling at around 100 mg. We are very cautious when we are using a dose more than 100 mg. We must monitor for bone marrow suppression. What are the side effects of azathioprine? Pancreatitis in about 4%, bone marrow suppression, particularly if there is a TPMT or thiopurine methyltransferase polymorphism, opportunistic infection, and theoretically increased risk of cancer. Let us come back to this patient. She was started on azathioprine 50 mg per day initially, gradually increased to 100 mg per day. Her total leukocyte platelet count was monitored initially every 2 weeks, subsequently every 1 to 2 months. Corticosteroid could be stopped, but while on azathioprine, her total leukocyte count fell down below 4000 per cubic millimeter. Platelet fell down to below 60,000 per cubic millimeter. Question is, what next? Now, azathioprine causes bone marrow suppression, and this is more common in those who have TPMT polymorphism. What is TPMT? Azathioprine is a prodrug which is converted to 6-mercaptopurine, which is further converted to 6-thioinosine monophosphate, and thioinosine monophosphate is converted to 6-thioguanine. Now what happens is 6-methyl-mercaptopurine and 6-thioinosine monophosphate are inactive metabolite, whereas 6-thioguanine is active metabolite. Thiopurine methyltransferase helps in conversion of 6-mercaptopurine and 6-thioinosine monophosphate to 6-methyl-mercaptopurine, which are inactive metabolite. So therefore, if somebody has a polymorphism of TPMT which lead to excess activity, more inactive metabolite will form and the drug will be less effective but less toxic. On the other hand, if somebody has a TPMT polymorphism which is associated with a reduced activity, they will have more efficacy of the drug but also more toxicity. Now what happens is, genetic polymorphism is this enzyme is transcribed from the gene, and there could be single nucleotide polymorphism in the gene which can cause to alteration in the activity of the enzyme. So TPMT genotyping was done in this patient, and we found that there was a wild type genotype which is associated with the normal enzyme activity. In fact, this is not uncommon. There are several Indian studies which showed TPMT polymorphism is uncommon in India. Still, we do see actually reduction of TLC and leukocyte count. What could be the reason? Now, this patient TPMT polymorphism I told was wild type, but her TLC further came down to 3,500, platelet to 40,000, and this there was a reduction in the hemoglobin as well, 9 gram per deciliter. The picture was megaloblastic with MCV of 120. At this stage, we always ask the patient whether she is a vegetarian, which is not uncommon in Uttar Pradesh, and in fact the patient was a pure vegetarian. We tested her serum B12 which was low. We started her on B12 injection and she improved. Her platelet count, hemoglobin, TLC improved, and she was continued on AJA successfully. Patient is in remission clinically at 2 years follow-up. Now at this stage, patient wanted to conceive. What to do? Stop AJA or should we continue it? Stop 5-ASA or should we continue it? Because one may feel that all these drugs are not safe in pregnancy, or should we repeat a colonoscopy and then decide? The third question first I take, yes, we should repeat a colonoscopy. Why? Because this is a study from Norway. This is a Norwegian population-based study showing influence of mucosal healing on outcome in patient with IBD. What is mucosal healing? On colonoscopy, if one finds that mucosa has become almost normal or normal, this is called complete mucosal healing. Also, there is a terminology called histological mucosal healing, which I am not going to talk about now. And people have shown that those who achieved mucosal healing on therapy had less chance of colectomy, less chance of relapse, and better quality of life than those who did not achieve mucosal healing, both in patients with ulcerative colitis and Crohn's disease. So therefore, documenting mucosal healing is important. In this patient, we repeated colonoscopy, she had complete mucosal healing. Azathioprine was discontinued. But let me tell you, current literature suggests that even azathioprine is quite safe while pregnancy. There are 2 large studies published in gastroenterology which found congenital malformation was not higher among patients taking azathioprine compared to those not taking. Therefore, if the patient comes today, maybe we will have to decide, but we discontinued azathioprine in this patient and we increased the dose of 5-ASA, and there was a successful pregnancy outcome. So this patient taught us that 5-ASA is used for maintenance of ulcerative colitis. In patient in whom steroid dependent disease is there, azathioprine helps in sort of maintaining remission. 3. Mucosal healing is important and that predict prognosis. 4. Azathioprine may be even saved during pregnancy, and better remission at the time of conception is associated with a better outcome of pregnancy. This is the second patient, known patient with ulcerative colitis for 2 years on 5-ASA maintenance after initial induction of remission using prednisolone 2 years ago. So question is that how does 5-ASA act? 5-ASA act in the colon in patient of ulcerative colitis. But unfortunately, 5-ASA is an acid labile drug. Therefore, one has to deliver 5-ASA in the colon. So how to deliver 5-ASA in the colon? One option is Salazopyrine. Salazopyrine is combination of 5-aminosalicylic acid with azo bond with sulfapyridine. Sulfapyridine is toxic, therefore most of the side effect of this drug is associated with the sulfapyridine moiety. Therefore nowadays we don't use salazopyrine very often in maintenance of remission of ulcerative colitis. We use 5-ASA instead. Except in patient in whom there is an extra intestinal manifestation in the form of arthritis, we use salazopyrine so that sulfapyridine works in the joint as well. 5-ASA can be delivered into the colon using enema, or it can be delivered systemically in the form of ulsalagine, which is a dimer of 5-ASA, balsalagine, which is a combination of 5-ASA with amino benzoyl alanine, or pentasa, which is a sort of a drug which is protected from destruction by gastric acid by a particular formulation. So how does 5-ASA work? It works by altering the formation of leukotriene and prostaglandin. It reduces bacteria-induced chemotaxis of polyps, adenosine-induced secretion. It inhibits nuclear factor kappa B, and it causes scavenging of reactive oxygen metabolite. Back to the patient. Patient came with relapse for 7 days, 8 to 10 stool per day with mucus, blood, urgency and tenesmus. Now my question is, how common is relapse in UC? How to manage? 15% of patients with UC will have severe relapse once or more in their lifetime, and the relapse severity is assessed by Truelove and Witt Severity Index. Here is the Truelove Witt Severity Index, which looks at frequency of stool, blood in the stool, fever, pulse, hemoglobin, ESR, abdominal examination and X-ray. The abdominal X-ray in this particular patient was normal. Now how to now manage this patient? The relapses are managed by inducing remission using corticosteroid or cyclosporine, and subsequently don't use the same drug for maintenance of remission, but use other drug for maintenance of remission. These are 5-ASA, salazopyrine, azathioprine, 6-marcaprine and methotrexate. Biological such as adalimumab and infliximab works both in inducing remission and maintaining remission. Corticosteroid is a wonder drug in this patient, and multiple studies showed that 70 to 85% patients, when they are given intravenous corticosteroid in severe relapse, they respond. However, steroid must not be continued for long. It must be tapered in due course of time because it has a lot of side effects like Cushingoid feature, osteoporosis, diabetes mellitus, hypertension, infections such as viral, tuberculosis, fungal, and it is further infective complications are compounded by azathioprine. Now, course of this patient, the patient had a severe attack, admitted, abdominal X-ray, no toxic myocolon. We gave antibiotic, IV hydrocortisone, 100 mg 4 times daily. No response in 7 days. So therefore, when a patient doesn't respond to IV corticosteroid in 7 days, then you diagnose that this is steroid refractory. So in oral steroid, dose not leading to response in 1 month is steroid refractory, whereas in IV steroid, 7 days is steroid refractory. What are the options then? Either you do surgery, the newer options are cyclosporine and infliximab. These are the predictor of poor response. This is one of our study where we found pedal edema. low hemoglobin, low fibrinogen, transverse colon diameter more than 5 centimeter, high C-reactive protein and very high clinical activity index is associated with failure of response. Now, does cyclosporine help in this patient? Yes. This is a famous study which was published in NEJM. 20 steroid refractory patient, 9 of 11 patients who were treated with cyclosporine responded. On the other hand, all 9 patients on placebo did not respond. Now, when 5 of these patients were crossed over to cyclosporine, at least all 5 responded. But problem of cyclosporine is toxicity, because toxicity include hypertension, low cholesterol, low magnesium, renal impairment, infection, seizure, even there can be anaphylaxis, and also there can be neurological side effect. Another reason why cyclosporine has been criticized in the initial studies is that when you give cyclosporine to this patient, though 80% respond, but most of them require surgery during next 6-month follow-up. So surgeon will say that you just delayed the surgery. Now currently recommended low dose of cyclosporine is associated with lower toxicity, but efficacy is almost equal. Another thing is that when you give azathioprine to this patient while stopping cyclosporine, most of them don't land up in surgery during next subsequent follow-up. Here is a study where patients of severe ulcerative colitis were treated with cyclosporine 14 and methylprednisolone 15. 8 of 15, that is 53% methylprednisolone group responded, and 9 of 14, that is 64% cyclosporine group responded. Now when azathioprine was given to these patients who responded to cyclosporine, 7 of these 9 patients, that is 78%, were well on follow-up and did not require surgery. So therefore, if you are giving cyclosporine to such patient, always actually maintain them with azathioprine. What is infliximab? Inflammatory bowel disease is a cytokine storm, particularly it is a TNF storm. And you can actually inhibit this TNF by infliximab. Because infliximab is a chimeric antibody having mouse as well as human antibody, they develop anti-infliximab antibody and there is a loss of response. Adalimumab is a humanized form of infliximab. This is supposed to be associated with less anti-infliximab antibody formation and better response in the long term, though the data is contradictory. Now infliximab dose and side effect, typically the dose is 5 mg per kg every 6 to 8 weeks. Now there are several side effects. If you know the market name of infliximab, this is Remicade, and from that you can remember the side effect. Remicade, RE is reaction, M for malignancy, I for infection, C for congestive heart failure, A for autoantibodies and anti-infliximab antibody, and D for demyelination. Now this is the document that infliximab work. This is Act 1 study where 364 patients with moderate to severe ulcerative colitis were randomized to placebo, infliximab 5 mg and infliximab 10 mg, and they found that infliximab 5 mg was superior to placebo, but infliximab 10 mg was no superior to infliximab 5 mg. So from this study, actually the data came which showed infliximab 5 mg per kg is enough. This is the Act 2 study which showed similar result. Now, can infliximab be used as a rescue therapy? That means whenever you have given a patient steroid and the patient is not responding, can you rescue the patient from steroid using infliximab? Here is the data which shows that yes, it does work in a subset of patients. Now, is infliximab better or is cyclosporine better? Here is the study of cyclosporine versus infliximab in steroid refractory ulcerative colitis, and it showed cyclosporine was not more effective than infliximab in patients with acute severe ulcerative colitis refractory to intravenous steroid. Therefore, you choose between the two, both are good, but only thing is infliximab is more costly. This is another set of data on cyclosporine versus infliximab in steroid refractory ulcerative colitis. It showed that infliximab avoids colectomy in 2 out of 3 of steroid refractory ulcerative colitis after cyclosporine failure. So what it suggests is, if cyclosporine has failed, then infliximab may work in a subset, and this study is important because I think we'll give cyclosporine fast because infliximab is costly. Now what is the course of this patient? Surgeon consulted the patient, did not agree for surgery, IV cyclosporine given, he responded in 5 days, discharge on oral cyclosporine which was stopped in 3 months, and azathioprine was continued well on follow-up. So this is the management guideline of ulcerative colitis. Moderate ulcerative colitis, oral steroid, taper according to tapering rule. Successful, maintain with 5-ASA. Severe ulcerative colitis, IV steroid. Now, if doesn't work, consider cyclosporine. If cyclosporine has been used to induce remission, give 6 mercaptopurine or azathioprine and maintain on it. Infliximab should be used, I think, where cyclosporine has failed. Obviously, in these patients, even colectomy is a good option. Thank you so much.